In this module, we will be focusing on the supply side of the market for healthcare. We will consider how providers behave under different market structures. After reading Chapter 6 in the text, you should be able to explain the various ways to characterize the market structure. Compare the characteristics of the healthcare market with those of a benchmark perfectly competitive market. Describe how an oligopolistic and monopolistically competitive market structure relates to healthcare markets. Evaluate the market structure of the pharmaceutical industry. And lastly, describe the trade-off between efficiency and equity in the healthcare market. You should be able to apply the general supply-demand model that we examined in Chapter 5 to public health and health systems issues, where we will consider the market for personal protective equipment and why there were persistent shortages in PPE over the pandemic years. You should also be able to explain how the monopoly and monopolistic competition market structures can be used to understand health and economic issues. Throughout this module, we'll be considering the full spectrum of market structures, from perfect competition out to monopoly and monopsony. In defining perfect competition, we have a market with many buyers and many sellers, each of which is small relative to the overall market, and there we have identical products being bought and sold, for instance, agricultural commodities. Under monopolistic competition, we have a market also with many buyers and many sellers. But here we have differentiated products being bought and sold. So you can think of the restaurant industry as being a monopolistically competitive industry. Now, under an oligopoly, we have a market with a few sellers, and under a duopoly, we have a market with just two sellers. In a monopoly, we have a market with only one seller. And under monopsony, that's the flip side of monopoly. In that case, you have a market with only one buyer of healthcare goods and services, for instance. So we'll be considering each of these market structures in turn, starting out with perfect competition. What do perfectly competitive market structures look like? Here we have many small firms where no one firm is a leader in the market, and also many individual buyers. Because these firms and buyers are small relative to the overall market, they can't influence the price or quantity and the material sense based on their own individual buying and selling patterns. We also have freedom of entry into and exit from the industry. So in this case, there are no significant barriers to entering a given market or exiting it. We also have homogeneous products. These products are not at all differentiated from one another, and that would apply in particular to certain agricultural commodities, for instance. We're assuming that firms are price takers in these markets. So firms take market prices as given, and they have no real command over the prices that are being charged. We're assuming that there's perfect information, for instance, about market prices, production technologies, or product quality, both on the part of buyers and sellers. We're assuming that there are no externalities or external costs and benefits borne by bystanders arising from activity taking place in these markets. And lastly, we'll find there zero economic profits to be had in the long run, such that all firms are making just enough to cover all of their costs, including the opportunity cost of resources or the time and energy of the founder. One quick definition before we take a look at the market structure under perfect competition. Note that the marginal revenue is the change in total revenue when selling one additional unit of output. In other words, that's the change in total revenue divided by the change in output Q. Under perfect competition, we'll find that marginal revenue is equal to the selling price in the market, and I'll show you why that's the case in just a moment. Here we have the market overall on the left with a downward sloping demand curve D0 and an upward sloping supply curve in the short run shown by SSR. So where supply and demand meet, we have the equilibrium price P being determined, and the firm in this perfectly competitive market can sell any of its output at that market price. So for each additional unit that it produces and sells at the market price, it adds that additional sale to its total revenue, and that's why the change in total revenue given 1 unit increase in output is equal to the market price. So now we have this bowl-shaped average cost curve. This tells us the cost per unit on average given the particular level of output. And then we also have the marginal cost of production, which tells us the change in total cost given a 1 unit increase in output. This is the initial equilibrium starting point both for the market and for the perfectly competitive firm operating in that market, and this constitutes a long-run equilibrium in our starting point for the analysis. So we also want to note that profit is the difference between total revenue and total cost. And since total revenue is P times Q and total cost is cost per unit, or AC, times the quantity of output Q, we could also say that profit is the difference between price and average cost multiplied by the quantity of output that is being supplied to the market by the firm. So this firm is taking the price as given by the market. This is price P, and then starting from this initial position, we're going to assume that there's an increase in demand in the market. And we know that from chapter 5, when we have supply and demand in a market, once we have an increase in demand, that's going to lead to a higher price and equilibrium, a greater quantity supplied by the market, and also a greater equilibrium quantity. This increase in demand leads to a higher price, at least in the short run. Now, the firm on the right sees this higher price level, and this is essentially a higher marginal revenue for any of those additional sales. So what they're going to want to do is expand output along their own marginal cost curve to where marginal revenue is exactly equal to marginal cost. Before that was taking place at QLR. But given this higher price level and higher marginal revenue, they want to set the additional revenue from sales equal to their additional cost of production in order to maximize profit. So they choose that position where price intersects marginal cost and then go down and produce that quantity. So that quantity, QSR, they're now selling each unit at the price of PSR, and they're incurring the cost per unit of AC at that level of output, which is shown here. So the difference between those two price and average cost for that quantity of output that the firm is producing in the short run, that is the firm's profit. So we see when the price is rising in the market, the firm expands output along its marginal cost curve, because now with that higher price, they want to keep producing more to take advantage of that higher marginal revenue. And they keep expanding output until that marginal revenue is just equal to their marginal cost. So this area in green is the profit that they achieve from the level of production. So in summary, an increase in demand from D0 to D1 leads to higher profits for a representative firm, but only in the short run. Because from that position in the long run, we're going to have more firms entering into this market, chasing after those profits that the incumbent firms are achieving. And entry to the market by competing firms exactly like the one on the right drives down the price until it's back to its long-run equilibrium level, PLR, so that downward and rightward shift in the short-run supply curve from SSR to S prime SR that leads to that falling price and a situation where all firms are again operating at that lower long-run equilibrium price. And now, at that point, there's no real incentive to enter the market because all firms are just breaking even. They're just making enough revenue to cover all their costs. And that is the situation we have right here at that long run level of output. So that would eliminate firm profits through competition. And the idea is that because of that, we'll get back to a new long run equilibrium. In this case, at a higher level of output, but at the original equilibrium price. And in the long run, under this constant cost industry where all firms have the exact same cost structure as the one on the right, and we just multiply them by a certain amount to comprise the overall industry supply, all firms end up making zero economic profits. And they produce the output level where price, which is equal to marginal revenue, is set equal to marginal cost, which is also at the minimum of the average cost curve. And this is kind of the perfect outcome under perfect competition because the prices that consumers are paying reflect the marginal cost of production as well as the minimum average cost of production possible. And that will not be the case under monopolistic competition, monopoly, or other industry structures. Now, note that this is a constant cost industry, but the healthcare sector is commonly viewed as being an increasing cost industry, and let's see why. So on the left, we have this increase in cost industry, and on the right, we have a decrease in cost industry. And that would characterize certain high-tech industries, safer cloud computing, for instance. So in both markets, suppose we have the initial equilibrium price and quantity of PLR and QLR as shown here. Now suppose that we have an increase in demand, which is going to be driving up price along the short-run supply curve in each of these industries. We have a higher price and greater quantity of output, at least in the short run. But in the long run, because these firms in those industries will now be able to charge higher prices and therefore achieve greater profits, this is going to attract entry by competing firms into each of these industries. Now in the healthcare sector, we have greater entry because of these higher prices, but at the same time, because we have many barriers to entry, which we will discuss later, ranging from education and licensure requirements to some regulations or patent protections that are granted by the government. The increase in demand here is much greater than the increase in supply, such that over time, in the long run, prices remain elevated, and that's why we have this long run supply curve that is upward sloping. This, in essence, tells us that prices tend to rise over time in the healthcare sector relative to other sectors, in contrast to maybe high-tech industries, for instance, say cloud computing. That initial increase in demand is met by an even larger increase in supply, and that leads to falling prices over time. That's why this long-run supply curve is downward sloping in these high-tech industries, and that's why we would call that a decreasing cost industry, because prices tend to fall over time as you have innovative cost-cutting firms entering the market and driving down prices. That is not the case in the healthcare sector. Over time, costs and prices tend to rise, and that's why we call that an increasing costs industry. Now let's use a model of supply and demand in the market for personal protective equipment to understand why we had shortages of PPE during the pandemic. Here we have a downward sloping demand, say in February of 2020, and an upward sloping supply in the market for PPE. Given the supply of PPE and the original demand for PPE, what would the equilibrium price per unit and equilibrium quantity in this market be? So here, the equilibrium price per unit will be $6. That's where supply and demand meet, and at that unique price, we have an equilibrium quantity of 2,000 units of PPE. But now suppose that demand rises considerably from the original demand shown here to the higher demand also shown here. Suppose that sellers of PPE maintain the original equilibrium price of $6 per unit. What would happen in the market for PPE given the now higher demand but maintaining the original equilibrium price? So the price of $6 per unit, the quantity demanded would be 3,500 units, but the quantity supply would be 2,000 units. This would lead to a shortage of the difference between the two of 1,500 units of PPE, as quantity demanded exceeds quantity supplied by that amount at that price. And this will be the case if sellers of PPE were hesitant to raise the price of PPE from the original equilibrium price of $6 per unit to the now higher price of $8 per unit. Now in practice, we saw sellers raising prices for many different goods during the pandemic. So this was a chart from the Financial Times taking a look at price hikes on Amazon.com for many pandemic staples, from face masks to disinfectant wipes to hand sanitizers and so forth. As you can see, that prices, especially those sold by third-party sellers, increased rather dramatically during that time. But since those price hikes, we've seen prices for face masks and toilet paper and other pandemic staples start to fall as supply of those goods and services began rising. Now, the flip side of perfect competition is monopoly. This is the polar opposite. Here, instead of having many sellers in the market, we only have one, and this seller is going to be able to set a fairly high price as there are no competitors to drive down prices. So previously, if we had an increase in demand driving up the price in the market, creating short-term profits for all firms in that perfectly competitive market, other competing firms would enter the market and drive that price back down to its long-run level. But in this case, over the long run, the monopoly firm will be able to maintain a fairly high price, and how high that price will be will ultimately depend on the responsiveness of consumers to those higher prices, which is a measure of the price elasticity of demand. Under monopoly, as I'll show you in just a few moments, we tend to have a lower quantity of goods or services than would be produced under perfect competition. We also have a higher price than the equilibrium price in a competitive market, and also a higher profit level for the firm. So high profits can be sustained into the long run under monopoly. But why do monopolies exist? We might have a firm that has control of a given resource, say by a patent-protected pharmaceutical company, or ownership of all or of some resources, say a regional hospital system. We could also have a situation where the government allows a monopoly to exist through the provision of patent protection, periods of market exclusivity, or the provision of other forms of monopoly privileges. There might also be a physical reason for a company to have a monopoly, saying electric utility or water utility, given that it would just be inefficient to duplicate that infrastructure. One example of a firm that has a near monopoly on a product was Allergan, which is now owned by AbbVie. And there was an article in Bloomberg Business Week talking about Allergan, or now AbbVie's $2.8 billion Botox empire. So here's an example of a government-granted monopoly in essence. Right now, health experts are divided over what it would take to effectively weaponize the botulinum toxin. But the mere possibility of a botulism bomb has the U.S. government on edge. That puts Allergan in a remarkable position. The government's vigilance enhances the company's own secrecy, and together they give Botox a near monopoly that is almost unassailable. Allergan says Botox has more than 90% of the market for medical uses of neurotoxins and 75% of the market for cosmetic uses. I used to say, how often do you see that distribution of market share in any category, not just drugs, just in anything, says the chief executive of the company. Until 2015, people used to laugh and say, I see what you mean, because it's just unheard of. So this is a good example of a firm that had a monopoly position in the marketplace. In essence, there are two types of pharmaceutical companies, and in practice might have pharmaceutical companies doing both. We have firms that engage in research and development to produce brand name drugs, and firms that manufacture generic drugs. So one study estimates that the average post-approval research and development cost for a new molecular entity developed entirely in-house by a pharmaceutical company was $2.9 billion in 2013. And that illustrates that this research and development process is quite costly. And it's also very lengthy and risky because some products never make it to market, even though you've spent years and years on research and clinical trials. We also have patent protection through the U.S. Patent and Trademark Office, or the granting of periods of market exclusivity by the Food and Drug Administration. These both serve as legal barriers to other firms entering the market and, in essence, provide a period of monopoly power for those firms. So Patricia Danson wrote that these are essentially legal grants of monopoly power to enable originator firms to recoup their R&D costs, and these patents can last for almost 20 years, while the exclusivity can vary. For instance, the FDA's orphan drug exclusivity lasts for 7 years, and those are essentially incentives for firms to incur the cost and go through this lengthy, costly, and risky R&D process to bring new drugs to market. The granting of monopoly power is why the pharmaceutical market is a textbook example of a monopoly or an oligopoly. Here, the price consumers pay for a new drug is much higher than the drug cost of production. And the more innovative the drug and the fewer close substitutes it has, the greater the price markup over cost the firm can charge. So let's seek to model the pricing and output decisions of monopoly of a firm in the pharmaceutical industry. Under monopoly or monopolistic competition, a firm faces a downward sloping demand for its product. When it's the only producer of that product in the market, it takes the entire market demand as the demand for its output. If it's competing with other firms, it still has some market power. This demand curve will just represent the demand for its product by its own customers. But under monopoly, you take the entire market demand as given, and you also face a downward sloping marginal revenue line. Let's see why that's the case. So if you charge a price of $40 where the demand curve is intersecting the vertical price axis here, that quantity demanded will be zero, and therefore total revenue will be zero. But lowering the price just a little bit from $40 to $38 per unit leads to the first unit sale, and that adds $38 in total revenue to the company. Now, for instance, if the firm is reducing the price of its product from, say, $36 to $34, revenue from sales for the first two units declines by $2 per unit, where they lose $4 from the lower price being charged. But now a third unit is being sold for $34, so the change in total revenue due to the price cut from $36 to $34 and the increase in quantity demanded from 2 units to 3 units, that changed the total revenue for that third unit is $30. So that's why we have the demand curve basically telling us the average revenue, or essentially the prices being charged for this drug. And then the downward sloping marginal revenue line is steeper than the original demand curve because of this relationship between total revenue and marginal revenue, and why a price cut tends to lead to an increase in revenue up to a point. So in essence, total revenue here is increasing, but it's increasing at a decreasing rate, and at some point it turns negative. So that point right there where it's turning from positive to negative, or the point of zero, it is a price unit elastic point. Before that, when we have a price cut, we see an increase in quantity demanded, and we know that when price falls and quantity demanded rises, in this area total revenue is going to be rising because this is a price elastic segment of the demand curve. So as we're increasing output and sales, that's adding much more to our total revenue. But at some point, we hit the price inelastic segment of the demand curve, and there a price cut will still lead to an increase in quantity demanded. But now we're losing so much revenue from the price cut itself relative to the new customers who are coming in the door that overall revenue begins to fall. And that's why marginal revenue from that point forward is negative. Right in between, as I mentioned, is the price unit elastic point, where a slight price change will lead to a slight increase in quantity demanded, but the overall net effect on total revenue is a wash. So that's why we have the price elastic segment on the upper level of the demand curve, the price inelastic segment at the lower level of the demand curve, and the price unit elastic point virtually in the middle. Now, as we'll see, a monopoly firm in the pharmaceutical industry will only be charging a price in the price elastic segment of the demand curve, because if they were lowering it to the point where they're in the price inelastic segment of the demand curve, they would be lowering their total revenue. So you can see this relationship between marginal revenue and total revenue here. Early on, as you're producing more and selling more, you are adding more to your total revenue, so you have a positive marginal revenue. Once you get to the flat of that curve, you top out on your total revenue, and then going beyond that point, you start to see total revenue fall, and that's why marginal revenue is negative beyond the price unit elastic point. So in essence, the firm is going to want to select a point somewhere in the price elastic zone on the demand curve. So we should note that pharmaceuticals tend to have relatively high fixed costs of research and development and relatively low incremental or marginal cost of production. And so they have a monopoly position and what Charles Hooper calls these extreme economics. But if you look, these extreme economics also apply to firms in other industries, say utility companies, telecom companies, large-scale manufacturers and retailers, software developers, social media companies, cloud computing companies, and so forth. Here, all of these industries have relatively high upfront cost of infrastructure investment, of capital acquisition and expenditure, but relatively low marginal cost of production. So we also know that firms are able to exercise considerable market power, that is to raise price well above those incremental costs of production. Here we have a downward sloping demand curve and a downward sloping marginal revenue line facing a pharmaceutical company. Now let's bring in the cost structure. We know the total cost is the sum of fixed cost and variable cost. Fixed costs are those costs that are not changing with the level of output and include things like the initial research and development outlet is the factory expenditure, the FDA approval process, and so forth. And then the variable costs tend to be relatively low, and those are things like ingredients or packaging. So average cost is just simply total cost divided by quantity of output. And so since you have those billions of dollars in research and development expenditures or building a factory or contracting with others for production, you have extremely high average cost for the first units that are being produced. But then the following average cost for the subsequent units as those major fixed costs are divided out among additional units. So the average cost curve looks something like this because of those economies of scale in production. And the marginal cost is relatively low once you've incurred those high upfront fixed costs. So if firms going to want to choose the level of output where marginal revenue is equal to marginal cost, anything before that point, you can produce more and you're going to be adding more to revenue than you are to cost. Anything beyond that point, you're going to be adding more to cost than you are to revenue on the margin. So that Goldilocks point is where marginal revenue is just equal to marginal cost. The firm's going to want to drop down to the quantity axis and produce that quantity shown by QM. Then they go up to the demand curve to figure out what price they can charge. And the height of the demand curve tells us the amount that patients or their insurers are willing to pay per unit at most, and they would charge this price PM accordingly. So with that price and that quantity, total revenue is shown by the area in blue. And for that level of output, we can go up to the average cost curve, figure out the cost per unit at that level of output AC, and total cost would be AC times Q. So with this total revenue and that total cost, the difference between the two would be the first total profit. That's total revenue minus total cost for this single product firm, or the difference between price and average cost multiplied by the quantity of output. So this is the outcome under monopoly, and here we have something like a 40% profit margin for that firm. Let's compare the outcomes under monopoly with the outcomes under perfect competition. We noted before that in the long run, under perfect competition, price is equal to marginal revenue is also equal to marginal cost, which is equal to average cost. Where the two meet, we have that long run supply curve, which is horizontal, shown by supply under perfect competition. Where that intersects the demand curve, we have the equilibrium price and quantity under perfect competition. Under monopoly, we can also suppose that marginal cost is pretty close to average cost in the long run, as that average cost continues to fall as you're expanding output. And so in this case, we're not going to have the competitive price and quantity being selected by the monopoly. The monopoly is going to want to set marginal revenue equal to marginal cost and produce that quantity there. Now, under perfect competition, we have a difference between the amount that consumers are willing to pay on the margin for each of these units, as shown by the height of the demand curve, relative to the price they actually pay, which is PC. So the difference between what consumers are willing to pay, or the height of the demand curve, and what they actually pay, PC, is a measure of consumer surplus. Now, under monopoly, when the firm sets price for the product here, that's going to be where marginal revenue is equal to marginal cost. And so where marginal revenue is equal to marginal cost, they drop down, produce that quantity QM, go up to the demand curve, and charge the price PM. So that means consumers are left with just the areas in green for consumer surplus. That again is the area below the demand curve and above the prices being charged in the market. Now, for each of those units, the monopoly is making a profit of the difference between PM and AC for all of QM that is producing and selling. So that's the firm's profit. The other area here refers to a deadweight loss associated with monopoly production and pricing. Because those units from QC down to QM disappear from the market as the monopoly is essentially restricting output to keep prices high, those units would have had a benefit to consumers that simply disappears from the market because of the monopoly's pricing and output decisions. So to summarize, in a constant cost industry under perfect competition, the long-run supply curve is perfectly price elastic. The horizontal line and price is equal to marginal revenue, which is equal to marginal cost, which is equal to the minimum of the average cost curve. And under monopoly, the monopoly firm is charging a higher price and produces less output than the perfectly competitive firm would. This leads to a reduction in consumer surplus. Some of that consumer surplus is transferred to the monopoly firm in the form of profits, while the remaining consumer surplus simply disappears from the market, and that's why there's this deadweight loss or lost social surplus, lost consumer surplus associated with monopoly pricing and production. So if monopoly means that there's one seller in the market, monopsony means that there's one buyer in the market. And if you'd like to read more about how that term monopsony was coined, there's a great article in NPR's Planet Money about the term monopsony. Here we're going to be considering perfectly competitive labor markets versus monopsonistic labor markets. So in perfectly competitive labor markets, there are many employers. We'll take a look at this in greater detail in the upcoming module. In imperfectly competitive labor markets, there might only be a few employers under oligopsony, or perhaps only one under monopsony. And this sounds abstract, but it's important to consider monopsony power in the healthcare sector, because some national governments may be the only payers for healthcare services, or there might only be one hospital in a region. And when that's the case, Those governments or hospitals have considerable market power with regard to setting prices, wages, and salaries. With a monopsony, we have a downward sloping demand for inputs, and we have an upward sloping supply for inputs. And the demand here is also the marginal revenue product of the inputs that the monopsony firm is employed. Under monopsony, the firm will purchase where its marginal cost of input utilization equals marginal revenue product here at QM. And so it chooses that level of output, or more specifically, input utilization, where marginal cost is equal to marginal revenue product. It drops down and selects that quantity of input to be utilized. And then it goes up to the supply curve to pay the minimum price per unit that suppliers are willing to accept for that quantity PM. In essence, under monopsony, the firm is paying a lower price and also purchasing fewer units than it would under perfect competition. We have a reduction in input utilization from QC to QM, and also a lower price being paid to input suppliers from PC to PM. This is kind of the flip side of monopoly, where the monopoly is restricting output and keeping price high, and in this case, under monopsony, they're limiting their input utilization and putting downward pressure on the prices that are paid to input suppliers. This also applies in the labor market. Under monopsony, the firm will pay a lower wage rate and hire fewer workers relative to the outcome under perfect competition. I've included a numerical version of this in the PDF of the lecture slides if you'd like to see how this marginal labor cost and marginal revenue product are calculated. Now let's turn to duopoly. Under duopoly, we have two sellers in the marketplace, and these markets are usually modeled using game theory rather than models of supply and demand. Price tends to be lower in a monopoly structure, but higher than it is under perfect competition, and the equilibrium quantity is shared between the two sellers. One healthcare example of duopoly is insurer participation in the ACA marketplaces. In 2021, for instance, 44% of counties across the country only had two insurers offering plans in those ACA marketplaces. In contrast, when we have three or more insurers or three or more producers in the market, we tend to say that we have an oligopoly, and this is essentially competition among the few. Here, this is also modeled using game theory. Each firm is producing goods or services that are similar but not considered perfect substitutes for each other. So you can think of Pepsi versus Coke, Uber versus Lyft, Boeing versus Airbus, to give you some examples. These are all operating in an oligopoly. And you can also look at small clinics in a given town, for instance, or urgent care centers locally could also be considered oligopolies. And here, through its changes in prices, output decisions, or advertising, each firm can influence its competitors' market shares in those markets. But we tend to see a situation where prices and output in these oligopolies move in the same direction. That's because we have interdependence in these markets. So here, any change in price and output by one firm has a direct effect on the profits of the other firm. And if one firm makes a change, the other firms are pressured to also change their prices and output levels. Prices and quantities tend to move in the same direction over time. We also have a greater reliance on advertising in order to gain market share, but we have we also have demand on the certainty because of the sheer amount of competition in an oligopoly. We see product differentiation, which gives a firm more market power, but we also have sticky prices. And the idea here is that if one firm reduces price, all other firms will likely do the same. So this reduces the incentive for any one firm to reduce its price. Perhaps that's why we've seen the prices for insulin produced by different manufacturers trending upwards very similarly over the past decade. You can see for 4 major producers of insulin, those prices have all increased at pretty much the same rate over the past decade. So this one chart reveals how the cost of insulin has skyrocketed in the US, even though nothing about the product has changed. Under monopolistic competition, we also have product differentiation. So firms are producing heterogeneous products, and one could point to the restaurant industry as being a good example of a monopolistically competitive industry. There we have many buyers and many sellers, and each seller has a relatively small market share. This would also apply to the market for physician services, for instance. Here we don't have cost minimization, and because of that, product differentiation is costly, and these firms are also price setters rather than price takers. And that's because each firm has some market power with respect to its customers, because of customer loyalty. Under monopolistic competition, firms can earn profits in the short run. However, higher profit levels lead to more providers entering the market to try to reach some of the potential profit, and existing providers further differentiating their products to attract more customers. So here we have a downward sloping demand facing the provider on the part of its existing patients, for instance. And they would also be facing a downward sloping marginal revenue line. Then we would bring in the clinic's cost structure as represented by this bowl-shaped average cost curve and this marginal cost line. The provider would see patients up until the point where the additional revenue from patients is just equal to the additional cost of seeing those patients. Then we select that number of patients up to QSR and then charge price P in order to maximize profit. At that level of service provision, we could go up to the average cost curve to figure out what the cost per patient is and the difference between the two. The price that they're charging and the average cost that they're incurring for all the patients that are being treated, that gives them that profit shown here in green. But the idea is that if in the short run that provider is making a profit, that's also going to attract other providers to enter that particular market. As other providers are entering that market, the demand curve facing the original provider is going to be shifting down and to the left as some of those patients might be going to another provider across the street. Then in the long run, that provider facing that lower demand, but the original cost structure, including the upfront cost of building the practice, for instance, will reach a point where the firm or provider is just breaking even. They're just going to be billing at the average cost of service provision. And so in the long run, the idea is that under competition in a monopolistically competitive marketplace, providers can achieve short-run profits, but because of the ability of other providers to enter those markets, in the long run, they will just be breaking even. To summarize, positive economic profits attract entry by competitors. When this occurs, demand for the incumbent firm or provider's product declines. This is shown by a leftward or downward shift to the original demand curve, and under monopolistic competition, entry by other providers or firms occurs until the average cost curve is tangent to the demand curve, at a price equal to average cost, and all firms will just be breaking even. So this is the outcome under monopolistic competition. In the long run, all firms are just breaking even. They're charging a price that's equal to the average cost curve, but they're also charging a price that's above the marginal cost of service provision. In essence, they're going to be behaving a little bit like a monopoly. They faced that downward sloping demand curve and downward sloping marginal revenue line. They're charging a price that's above the marginal cost of service provision, but they're also charging a price that's equal to their own average cost of service provision. Under perfect competition, we're going to see firms charging relatively lower prices and producing a bit more output than we would have under monopolistic competition. To summarize this, under perfect competition, goods are produced and sold at the lowest possible average cost. This is not the case under monopolistic competition, as product differentiation is costly. Prices tend to be a bit higher under monopolistic competition, but that's essentially the price we pay for variety and innovation and product differentiation. Most healthcare markets are not perfectly competitive. We have barriers to entry in most healthcare markets. Think about the time it takes to build a practice, the education and licensure requirements, the regulations and legal restrictions, including scope of practice regulations, certificate of need laws, patient protection, periods of market exclusivity. All of these and more prevent potential competitors from entering markets. So in practice, we do have some barriers to entry in healthcare markets, and that takes us away from that perfectly competitive market structure. When we have relatively few firms or providers in the industry, this gives rise to considerable market power, and that's the ability to change different prices or pay different prices for input suppliers, and also influence the quantities that are produced or bought in those markets. Healthcare services tend to be highly differentiated regarding equipment and diagnostic capabilities, patient and provider interactions, for instance. So this is not a homogeneous product that is being produced. We also have motivations beyond profit maximization in the healthcare sector. So we consider both efficiency and equity with regard to how healthcare goods and services are being produced, financed, and delivered, as Burnell notes in the text. If only efficiency is considered. Only those who can afford health-related goods and services will purchase them. You have access to affordable health care is often viewed as a human right, and one that is not predicated on an individual's ability to pay or the height of the demand curve. We also have considerable uncertainty in the healthcare sector, for instance, regarding the effectiveness of different treatments or diagnosis or patient health status. And this, in essence, has given rise to the entire field of health economics, starting with Kenneth Arrow's paper in 1963. In that paper, he pointed out that in the healthcare sector, we have imperfect information or asymmetric information where the seller has more or better information about the product than the buyer does. Also, maybe the patient has more or better information about their own health or behaviors than a health insurance company would. We also have the presence of externalities in the healthcare sector, and these are external benefits associated with vaccinations, for instance, or external costs associated with smoking or antibiotic resistance. These are essentially external costs and benefits arising from market activity that affect people who are outside of those markets. So when people are getting vaccinated, that creates a positive externality for those who have not yet been vaccinated because of herd immunity, for instance. And if people are smoking, that can impose costs on others who are also not smoking. We should also note that public and private insurance coverage affects ability or willingness to pay for healthcare goods and services. That's something that was not really considered in this module, but was considered in the previous module and will be considered going forth as well. And then lastly, we should also know the prices and quantities are affected by a third-party payer and their negotiations with providers and manufacturers. So in practice, the prices and quantities that are utilized in healthcare markets can be quite complex. So one last tool with regard to market structure, the Herfindahl-Hirschman Index, or HHI, is the traditional measure of market competition or market concentration. This is essentially a measure of whether we have perfect competition, monopolistic competition, oligopoly, duopoly, or monopoly in a given market. The HHI for a well-defined market is simply the sum of the squared market shares of firms operating in that market. If we only have two firms in a market, we have a duopoly, and the two firms evenly share the market, then the HHI for that market would be 5,000. Suppose we have three firms in a local market, say one of the ACA marketplaces, for the number of insurers participating in that marketplace. If firm 1 has a market share of 60%, firm 2 has a market share of 30%, and firm 3 has a market share of 10%, then the HHI for that market would be 4,600. And note here that the largest firm has a greater weight in the HHI. If there's only one firm in the market, the firm has some monopoly, then we have an HHI of 10,000. In sharp contrast, if we have 100 firms in the market, each with the same 1% market share, then each of those firms would have a 1% market share and the HHI would just be 100. Here's a practical example using 5 firms. If firm 1 has a market share of 39.9%, firm 2 has a market share of 29.2%, firm 3 has a market share of 16.4%, firm 4 has a market share of 13.3%, and firm 5 has a market share of 1.2%, then the HHI for this industry would be 2,892. But then the question is, which mystery industry is this? Is this the auto industry in the US, the airline industry, the market for smartphones, the market for wireless carriers, or the market for search engines? If you answer D, that would be the correct answer. This is the market for wireless carriers. You can see that AT&T has the 39.9% market share, followed by Verizon, and then T-Mobile and Sprint. You should note though, and T-Mobile just recently acquired Sprint, so that is merged in this pie chart. And this is essentially the overall breakdown of market shares for that industry and also the HHI for that industry. As stated earlier, the HHI is the traditional measure of market competition or market concentration. And if it's closer to 10,000, that means there's very little competition in that marketplace. If it's exactly at 10,000, then we have a pure monopoly and there's no competition. If it's closer to zero, that means there's a lot of competition and it's getting close to a perfectly competitive marketplace. HHIs may be used by the courts and the Department of Justice and the Federal Trade Commission when screening proposed mergers and acquisitions. If you have a merger leading to an increase in the HHI of more than 200 points, it's presumed to be likely to enhance market power. And that is when the DOJ or the FTC or the courts would view that as moving into a more concentrated market. If the HHI is above 2,500, it's viewed as being highly concentrated. And if it's between 1,500 and 2,500, it's moderately concentrated. If it's below 1,500, we say it's unconcentrated. So what does this look like in the healthcare sector today? For hospitals on average at the MSA level, the HHI is more than 5,500. For specialty physicians, it's almost 3,500. Insurers come in around 3,000, and for primary care physician, it's about 2,500. Keep in mind that the HHI for a market with 4 firms, each with 25% market share, was 2,500. And that's pretty close to where we are with primary care physicians. For duopoly, it was 5,000, and we're above that for hospitals, and that reflects the fact that we've had high and rising concentration in the hospital sector. Especially the growth of hospital systems acquiring smaller or independent hospitals. And that's why we've seen the HHI for hospitals grow over time. But this has also been the case for specialist physicians, insurers, and primary care physicians in recent years. The following few slides serve as an appendix for monopsony in the labor market. And here ends the slide presentation for Chapter 6.